We're going to talk a little bit about renal failure and the emergency department and the kinds of things that we do. And not only renal failure, that they come in with renal failure, but we cause renal failure. We have things that cause it. And we need to be aware of the fact that you can be a cause. Fact. Contrast for X-ray causes about 12% of hospital-acquired renal failure. Pre-renal, having had some problem beforehand, and diabetes tend to be the key factors here. Diabetics don't do well when you fill them full of contrast, and if they had an elevated creatinine before you saw them, you're not helping them, are you? No, it never lowers their creatinine. Question number one, are there certain patients who don't need a creatinine? Well, that's a very good question. How many people here, their radiology department requires a creatinine before any dye study? Well, you might want to share this with them. There's a 1996 article out of the New England Journal, very good, that said, yes, high-risk patients, again, those people who have, and here's how you define high risk. Those people with diabetes, over 60, hypertension, coronary artery disease, failure, or hepatic disease, that's the group that is high risk. They had about between 9 and 16% had some significant rise in their creatinine. Now, that doesn't mean it doesn't come back down, but we should recognize that. However, if you didn't meet that, it was only 1 to 2%. And they couldn't figure out which 1 to 2% that was going to be. So the conclusion really is, yeah, high-risk patients, you might want to know it, but just understand, in low-risk patients, there isn't much of this. By the way, paper 2 said, they used 2,000 patients and said, well, how would you know who needed a creatinine? And they said, by history alone, if you just ask those questions, do you have heart disease? Do you have kidney disease? Are you a diabetic? That would have essentially picked up everybody who had a problem. You really didn't need it. Number 3, University of Maryland study. I like this study. And the question being asked here is, well, if you've got the BUN, how many people when they have that little Chem 6 or 7 get a BUN on it? Well, the truth of the matter is, if your BUN is 15, is your creatinine going to be abnormal? No. At the 99.5, between 99.5 and 99.9, if your creatinine is 15, or if your BUN is 15, you don't need a creatinine because it's normal. Even if your BUN is 20, only 4% had any elevation in the creatinine. That's pretty good, really. So if they didn't fall into a high-risk group and their BUN was like 17, just go ahead and do it. I mean, waiting around for the creatinine to come back, probably unnecessary. By the way, can the dipstick, the urine dipstick, tell you if they've got kidney disease? You say, well, that's kind of strange, that doesn't relate to anything. Yes, it does. This is actually a recent study. This is a Cleveland Clinic study, number 4, and I'd star this one because it says the urine dipstick was abnormal in all patients with a creatinine greater than 2. Now, most of your radiology departments are worried about creatinines greater than 2, right? Here, abnormals, everyone in the study who had a creatinine greater than 2 had some finding in their, usually protein in their urine. I think that that's very reassuring. You do a dipstick on somebody, your chances of causing them any harm, real tiny. Article 5 reiterates that. This is a completely different program. This is the one done at Temple. But again, the urine dipstick, and let's read the statement right out of the paper. Urine dipstick picked up everybody with renal compromise, as defined by a creatinine greater than 2. So there you go. Normal dipstick. They give a history and they don't have anything to go along with it. Do the study. Should N-acetyl, next question, question 4. Should N-acetylcysteine be given patients prior to contrast administration? Now, you all know that there has been some study that says that the N-acetylcysteine is protective, but the problem is this. If you give the N-acetylcysteine 2 days in advance, yes, there was a decrease in the rise in the creatinine. Nobody argues with this. How often do you have in the emergency department 2 days to decide? So the real question is not is 2 days protective, but what about right away? Article 6 is the New England Journal of Medicine study, the 2000 study, which again, there's no question that given 2 days before, it was somewhat protective, and it prevented a rise in the creatinine. But nobody has got a study that says it's that good short term. In fact, let me just get this here. 10 and 11, the summary, if you have time, if you have 2 days, fine, give N-acetylcysteine. If you're going to give it the hour before you do the study, we have no reason to believe that that's protective. Article 12 is the Canadian Journal of Emergency Medicine, 2004, so it's a recent study. If given in the ED just before the procedure, no effect. And actually, this is a well-done study, where they took them and within the hour of getting the study, they got the IV N-acetylcysteine, no benefit. So as far as we're concerned in the emergency department, it ain't going to help you out. Just won't work. Question 5, what about metformin patients? How should they be handled? I take metformin, and when I had to receive an angiogram, a cardiac study, they were all upset and this, that, and other thing. We're going to have to run you this or that. Here's the fact. The danger in metformin is related to acidosis. Acidosis only occurs if they take it after getting the renal failure. So you shouldn't be so concerned about stopping it 2 days before they get the study. What you should be concerned about is making sure you stop it for the 2 days after they've had the study and then can clear it. But you know what? We didn't figure that out for a while. This is actually relatively new information. How many people here did they get upset about in your department if they were on metformin? Don't they ask that question, are you on any medication for your diabetes? They should just ask, are you on metformin? Because that's the one they're concerned about. They don't care if you're on something else. They don't care if you're on Evandia and that sort of thing, if they're giving you, if you're giving contrast. But that's pretty good. Article 13 is from clinical radiology. This is not an emergency medicine study, but it is the fact that this drug will deal and interplay with acidosis. So here's what they recommend. This is right out of the radiology journal. So give this to your radiologist. Stop it 2 days after the procedure. Now, what they also recommend is if you know you have a patient with some renal failure or high risk, you can probably stop it 2 days before as well. Sure, we're okay with that. But that's not the critical time period. The critical time period is the 2 days afterwards, and that's when you need to warn the patient. Question 6, what type of contrast should be used and in which patients? This is a money question. There are 3 kinds of contrast materials. There's high osmolar, which is readily available, and what's the beauty of it? It's cheap. It's very cheap. We can buy a gallon of it for $1. I mean, it's not that cheap, but it's cheap. No question about it. It's between 15 and 20 and sometimes 25 times cheaper than the other stuff. We have low osmolar but high ionic, and then we have low osmolar, no ionic. That's very expensive. That's very expensive. So who do you think is going to do a study on this? Well, the British or the Canadians. It just so happens this one's the Canadians. The Canadian study, radiology, asked this question. In high-risk patients, what should we do? Well, it's very clear. If you fell into that group we talked about earlier, go low osmolar because they had a higher risk of having a problem. But what they said was, in people who were not high risk, the actual chance of raising the creatinine was small, and the rise in creatinine is relatively small, and it usually goes back down. So the conclusion of the Canadian study was, in patients who are low risk, go ahead and give them the cheap stuff. What about the possibility of having a reaction to the medication? Yeah, it is a little bit higher, in the higher osmolar material. There's no question about that. But again, the Canadians look at a cost-benefit analysis and said, it's so rare that they died. And maybe if they died, God was just thinning the herd anyway. You know, maybe you deserve to die or something like that. So they are recommending that you use the cheap stuff in those folks. So Article 15 goes on this again. Again, a cheap study, which says, go ahead and use the expensive stuff, the expensive spread, in those patients with known renal failure who've had known complications with other medications. Question 8. Should sodium bicarb be used to pre-treat nephropathy? Very good study here, and star it, number 16, because this may actually change your practice. This is a 2000 study from JAMA. And what they said was that with a known elevated creatinine, if you give bicarb 1 hour before the procedure, remember we did that with the N-acetylcysteine, it sucked, it was no good. But remember what we said, the problem was the acidosis and what happens in your renal, in the tubules and that sort of thing. What this says is, and this is a really well done study, 1.7% in the procedure, 1.7% had a mild elevation in their creatinines, 1.7% if they got the bicarb. If they didn't get the bicarb, that increase was 13.6%. See, I think that that is real stuff. So if you're going to use a contrast material for something, and I don't care what it is, this giving of the bicarb, this is not, this is real data, and it relates to us in the emergency department, because we can go ahead and do it. What I would suggest to you is take it back to your radiologist. Say, do you believe this? What's your literature base? Because we're happy to run these people, if we have the time, run them a little bicarb. We got bicarb sitting around everywhere, right? We got all these vials of bicarb. Why? Because we're not giving it anymore in cardiac arrest. It's like all the calcium we got sitting around. And if you don't think that calcium hasn't been trashed, you should see what happened yesterday. Did you see the article that was released? All these women on calcium and vitamin D, how did they do? Worse. There is no proof that postmenopausal women with calcium and vitamin D did better. In fact, they did worse, and they are 13 times more likely to develop a kidney stone. This has not been a good week for myths, okay? Because the low-fat diet in colon cancer, breast cancer, and cardiovascular disease got blown out of the water. Goodbye, Jenny Craig. Hello, Sarah Lee. Okay? What can I tell you? In the article, there's a formula there for the bicarb. I did not write it down, but it's actually a relatively small amount. You know, it's what? It'll be different in 3 years anyway. But I mean, this is actually 1.7% versus 13%. This is a real difference, and this is statistically validated number, big numbers. So I think this is good stuff. Number 9, should diuretics be given to treat renal failure? How many people grew up where we just sort of automatically added a slug of Lasix or B-Mix? Yeah, we all did. Okay, this sounds right? Because we make them pee. That's the aim, right? No. What we should be doing is making them pee with the bad stuff, so the kidney is actually still filtering. We can squeeze blood out of a stone. We can beat the kidney till it produces fluid. That doesn't mean it's got anything good in it. JAMA, 2002, a retrospective study. Diuretics did no good in the outcome of patients in renal failure. The Australian study, number 18, beautifully done study. These were sick people, ICU, 1,700 patients. Diuretics did no good. Article 19, this is the one you star. The loop diuretics, there is no question that we made more fluid. There is no question that the creatinine did not come down. So the objective measure of renal function was not influenced by putting them on either low or high dose diuretics. So just understand, if the kidney is failing, Just beating it, whipping it with a hose, with a chain, is not going to actually give you better renal production. When they're going down the tube that way, they don't need Lasix, they probably need dialysis. And it's probably a waste of time. Article 10, is low-dose dopamine useful? Well, what's the theory here? We all grew up with training that said, oh, a little dopamine, that's a vasodilator. And it also increases kidney flow. Well, let me just tell you this. All those studies were done in what kind of animals? Normals. If you have bad kidneys, does it do the same thing? Well, that's the question they asked. We know that in normals, it gives us a little bit of vasodilatation, a little more renal flow. It did not work in sick humans. Article 20, this is a combination Australian-New Zealand study, and a big one for them. 324 people critically ill. They ran them low dose, medium dose, dopamine, absolutely zero effect on urine flow, creatinine, BUN. It just didn't work. Let's summarize this. The kidney is an organ that we can't do much about. Can we all agree on that? It's like the brain. I mean, if you actually need to go into it and do something to it, you're in deep shit, aren't you? That's exactly. See, it's not like the bowel. We can operate on bowels. We can do things with other things. But the kidney itself, the actual parenchyma of the kidney, there's not much we can do about that. And unfortunately, dopamine, Lasix, all that kind of stuff did not influence the outcome. And I think that, and I know everybody's got protocols here or have been trained that that's the stuff you're going to give. None of the current literature supports that. University of Pittsburgh study is a good one, 21. No benefit from dopamine. University of Toronto. You know, the University of Toronto, the study I think is probably the best of the group. And there may be a suggestion in that literature, and it's just a little bit shy of being statistically significant, that they did worse. Now, I don't know the exact pathophysiology of why they would do worse, but they certainly didn't do better. So it's not a close call here. Just don't bother with it. Question 11, can albuterol be used to emergently treat hyperkalemia in renal failure? Now, what we have all grown up with is insulin and glucose, right? We can force that stuff back into the cell. We can also give them XK-Lite if we want, and be prepared to clean up that mess. But we can do that as well. Here's something which we don't do enough of and works just fine. Fact, albuterol makes K move into cells. Fact, I mean, that's well known scientifically. What about its clinical significance? Well, there's a Spanish study, 23, where they tried salbutamol, which is albuterol, versus glucose and insulin. What did they find? The salbutamol caused a mild increase in the blood glucose, not much, and no hypoglycemia. You see, the problem with doing glucose and insulin is what? You can overshoot. In fact, 20% of the people in their study, where they were going after the K, had a bad problem with the glucose. So they did better with the salbutamol. Article 24 is the exact same study with the exact same results. What it says is this. If you're in the department and you need to emergently lower K, when would we like to do that? Well, if I have somebody in renal failure who comes in, we have people who are not terribly good behaviors, and now they've missed a dialysis, or they were this or that or something else, and now it's 7.5. At 7.5, you've got my undivided attention on this thing. Because I know at 8.5, you're probably going to do what? Die. So you have to do something. And now you've called over to the dialysis center, and they say, well, I don't know, he misses the point. I said, shut up. Just did it. What this will do will give you 120 minutes of decreased K. 120 minutes. And that's usually about the time you need to get these people over to dialysis and get them going. But you want something which is not going to screw up their glucose, Because are most of these people also diabetics? Yes, that's whose kidneys fail. So the last thing they need to have is more trouble with their glucose. So give them this. What about if we just had them inhale albuterol? Treat their asthma at the same time. Well, the bottom line is it works, just not as well as IV. And so it's about half as effective breathing-wise as if you give it to them through the vein. Believe me, when these articles started to come out, it changed my behavior, because I was treating them with glucose insulin, and now I'm not doing that anymore. And it's not every single day. I mean, the nice thing about our dialysis patients in the dialysis center is they run pretty much independently of us. It's very rare. When those guys over there send us somebody, they're sick, because they see sick people every day. And so they know what to do about it. And that 120 minutes, I forget which article, Article 25 gives you the timing on this. But that 120 minutes can buy you serious time before you get them dialyzed. By the way, our dialysis people are so good. I haven't actually done a peritoneal dialysis now on anybody in years. I don't know how many of the rest of you are doing that procedure anymore. Did I learn how to do it? Yep. Did I do a lot of them? Yep. Dialysis center is so good, they just get those people in. It's wonderful. Number 12, are elevated tropin levels significant in the face of renal failure? Fact, elevated tropin, for no matter what reason, is bad. If you actually have a significantly elevated tropin, your chance of being dead in 4 years are real good. It doesn't matter why it is. But Article 26 from CHEST, this is the one that says bad outcome from no matter what cause. 27 is the Academic Emergency Medicine article by Domino. This is a well-done study. It's out of Henry Ford. And what they did is they followed troponin I's both before and after dialysis. Okay? We found before and after. What they found out was most people in renal failure do not have elevated troponin I's. So believe it, when they come in with an elevated troponin I, assume it's from their heart. Do not assume it's because they have renal failure. Because the vast majority of people in this study, and 27 is the one you should star here and you should look at seriously. This is the study that really says, you know what, it's not your kidney. Troponin I's up, it's your heart. And I like that study. It's beautifully done. Last couple of questions here, and then we'll take questions and I'll be done. Question number 13, should aminoglycosides be given once daily? This problem has been decided. Again, all of us grew up with gentamicin Q8 hours. We gave the first dose a milligram per kilogram, and then we adjusted it based on the creatinine. No, that is not the best way to do it. You're much better with peaks, with the big overshoot, when this stuff gets somehow incorporated into the bacterial cell membranes, and then troughs. That's a much better technique than a smooth. See, we all believed in the smooth level, right? Keep it level. That is not the way to kill bugs. And now we're onto this. So, and here's the other beauty of this. Cheaper is better. And when you actually look at giving the drug, nursing time and pharmacy filling times are the cost of the drug. I mean, a lot of this stuff we can buy by the gentamicin now, we can buy by the tank car load. It's a relatively cheap drug. So 90% of the cost of gentamicin is the preparation, delivery to the floor, nursing time to hang it. And by the way, if any time you have to give something 3 or 4 times a day, are they more likely to screw it up? Yes. If you look and see the principal reason for drug errors in the hospital, it's not that we gave somebody a huge mammoth wrong drug, it's it didn't come in the time range which is considered acceptable. That's a much more common problem. So the nice thing about once a day is blast them hard, let it fall. And they give some dosages there. Peak value is what's important. Once a day is better, And there's no proof that the renal toxicity, your BUNs, all that kind of stuff, is any worse with giving it once a day, big dose, as opposed to small dose 3 times a day. There is no data to suggest that this is worse on the kidney. Again, I think that's useful. Article 30 agrees with this. Article 31 is one you want to circle. There's the people who say, go ahead, instead of doing the 1 milligram per kilogram 3 times a day, do 3 milligrams per kilogram once a day, and then let your pharmacist adjust based on the creatinine. All set. Any questions? Any comments? Sir?
Do you have any comments about the actual incidence of nephrotoxicity from ketorolac? Which we used to, when we were doing IUD,
Yeah.
it probably was more significant than we're doing CAT scans for kidney stones.
Exactly.
But we still use it.
There is no question that ketorolac has some renal toxicity. Here's my suggestion for you. Ketorolac is a mediocre to poor pain medication unless it deals with one issue: hollow viscous spasm. So if you've got somebody with a broken leg, I wouldn't even know what Toradol is for. In their burn, in their this, in their that, it's probably not useful. I'm willing to buy the complications when I've got somebody with hollow viscous pain. Anybody here ever had a kidney stone? Yeah. Is it fun? Yeah, it's a lot of fun. I never had a pain like that in my life. And I've had a 6-vessel bypass. I've had all the usual stuff. Yeah, an irritant, minor irritant. You know, I was out for 4 days and went back to work. When I had my kidney stone, I went to my knees, and the morphine, 15 milligrams of morphine, barely touched it. They went like that with the ketorolac. 10 minutes later, I'm asking to go home. It's unbelievable. Also, you see women with pain related to the ovaries and the tubes. Very useful. I don't think it's worth a damn on a lot of other kinds of pain. But at least in hollow viscous pain, that there is some that relaxation phase, which it does, which is actually very good. So my view of ketorolac is limited use. There is a nephrotoxicity associated with it, so I don't want a lot of it, and I want it only for specific purposes. By the way, there's some debate about, is it worse orally than it is through the vein? When the stuff came out, you remember that there was a 60 milligram dose, right? Funny, the oral dose was 10 milligrams. What other drug do you know of? Just name me one other drug where the IV dose is 6 times that of the oral dose. So finally they started to look at that question, and there was no question that it was dose dependent, the nephropathy. So the 60 milligram dose, I believe, is gone. It's taken off the market. It's not even there. The 30 milligram is what we're using at this point in time. And again, is there some nephrotoxicity with it? Yes, there is. But again, I'm willing to trade that off for certain disease entities. And I don't know how you're using it, but it's a poor, pure pain medicine. I think it's mediocre. Yes?
I just had a situation where a woman with kidney stone pain came in, history of kidney stone, gave her the Toradol, and it relieved her pain. Unfortunately, got the Chem7 later on, or the metabolic profile, and her creatinine was 1.7. And the urologist, they're like, I've seen patients go to dialysis after 1 dose of Toradol. I was just wondering if there's any literature, 1 dose of Toradol.
You know what?
Really?
There's so many of these guys who are into testimonial medicine. What you should say is, would you bring me the literature on that?
Actually, I did.
Yeah, that's right.
But
See,
I haven't seen anything.
Because I've seen this. Well, so what? Okay, I've seen a lot of other things too, which I'm not quite sure about. That's not a scientific view of what we do. And to me, at this moment in time, when I have a kidney stone patient, that's what I'm going to do. And by the way, I don't wait until I've gotten the CT scan back. I start the HEP block, I give the stuff, I usually do that, and I'll give them a morphine chaser on top of it, send them over, and by the time they get back, they're reading a magazine feeling great. And that's exactly the way I want it to be. Will there be occasional person? By the way, 1.7 is not critical. There's all kinds of people functioning at 1.7. More than that, if it is due to the TOR, and after how long a time did you get the blood back?
Well, no, the blood work was done before receiving.
Right.
She had the blood work done at triage.
It wasn't due,
wasn't.
and at 1.7, nobody's going to say that that's a critical value where you can't use the medication. Nobody's going to agree with that.
1.7 is from the ACE inhibitor she's on.
What?
1.7 of serum creatinine, it's because of the ACE she's on. She must be on captopril or...
Well, that certainly could be
Yeah.
that certainly could be the same as well.
You don't stop ACE inhibitors at 1.7 of creatinine. You never do that.
No.
I have a question. When the radiologist asks for the serum creatinine, which is to be done within 72 hours, I mean to say the patient had the creatinine done like a week prior to this CAT
Right.
scan. So what do you say to them, that it was normal a week prior, but they said no, it has to be done within 72 hours. So
I think they're unaware of their own literature, because their own literature would say, unless they're in flagrant renal failure, I mean, this is a normal value, right?
Yeah.
Yeah. It's going to be normal. The other thing you should say is, the dipstick's normal. Dipstick urine's normal. And remember, we talked about that. There was no dipstick above a 2, and these are people with diseases across the board. You might hold gram rounds. Let me tell you how you solve these things. We do a lot of this, and that is we bring our literature to a meeting and have them come to the department meeting and say, we're going to discuss this issue. I remember when we moved over to using no eye patches after small corneal abrasions. Well, we brought one of the guys from Opti. We brought our literature. You know what he brought? Nothing. He hadn't looked at anything. We said, well, this is what all this says. More than that, you can get a micro drop bottle, enough for 16 hours of the pain medication. Remember, it was almost like a crime to send a patient home with pain medicine. The difference is, if it was a doc who got an abrasion on the eye, what did he do? Took that damn bottle home. I mean, it's terrible. It's very painful. So now we get these micro dropper bottles. Really, they got enough drops in there for the next 8 to 12 hours, something like that. We just give it to them. We do the first few drops here, take it home, use it again in 4 hours, use it again in 4 hours. Come on back in tomorrow if you have any problem. And by the way, if you're completely normal, you are normal. If you need more pain medicine tomorrow, you better come back and be seen. But, we get into this, everybody's got to be rechecked. The truth of the matter is, the body's pretty smart. If you're absolutely pain-free the next day in the eye, do we ever find anything? No, we don't. Inflamed eyes are painful and they show up. Normal eyes are normal. And the recovery time on a corneal abrasion like that is somewhere between 12 and 16 hours. They're reepithelializing and they're just fine. So I think that's the technique of choice now in handling those folks. Any other questions? Question?
You were talking about Toradol, but what about the other anti-inflammatories as far as, some patients don't have ibuprofen, and do you put limits, just don't take it for more than a few days?
Well, the reason I limit ibuprofen is not the renal complications. See, I think ibuprofen is the gut wrencher of the society. All the data is the same. That is, the first 3 days, fine. When you move after about 3 days of high dose, you start to kill off cells, and by 7 days, virtually everybody has changes in the lining of their stomach. So I'm a limiter of the drug, high dose early on, rapid taper, more for the GI effects than the renal effects. I think the renal effects are relatively small. They're not a 20th of what the GI effects are. They're really much smaller. Yes?
The IV salbutamol for hyperkalemia?
Yes.
That must be licensed only offshore, nothing in the U.S.? Or have they used it here? Is there an IV formulation that I don't know about? Or is it like N-acetylcysteine? You give the oral stuff, you just give it IV before they came up with fancy drugs?
That's exactly right.
Or are we waiting for it to be licensed? Or is it just like respiratory?
I can't tell you whether it's sort of an off license usage of the drug. But the stuff they use is the same stuff they pour into the machine. You can give it to them IV, and again, its effect for the next 120 minutes while you're setting them up for dialysis is terrific. I mean,
and one of these, it looked like it was synergistic. Just briefly reading through the abstract, it said you add that to the D15 insulin, and
you can add, no, the one study done did it this way. They said, let's use glucose and insulin, let's use albuterol, then let's use the two of them together. There is no question that the two of them together gave a little better result. The bottom line is this: how good a result do you need? See, if I have somebody who has renal failure who are going to get set up for dialysis, all I want to do is gently drop their K a little bit until they can be dialyzed. I don't care if it shoots to the bottom. And so although the combination is a little better, do I want to buy the possibility of hypoglycemia, which is what I buy with insulin and glucose? So we ought to think about that.
For your kidney stone patients, I'm from Phoenix, it's like kidney stones to the max.
Right.
You throw a little Compazine or Peritol with the morphine and Toradol?
I can.
Yeah, you can.
Right, exactly. And you know what? Whatever combination works for you, and I think that the new standard should be, though, before they go to get their study, their stone study, you're treating the pain when they walk in the door. Because then by the time they're laying on the table for the CT, they're much more pleasant people and much happier campers. Ma'am? Well, I actually was raised as a neurologist, and let me tell you this. There's at least 25% of people who will respond to nothing, right? And there's always a group of people who oh, I'm really good with this, not with that. I have some people who get a wonderful effect. Understand, this has to do with inflammation. Migraine has to do with inflammation of the fifth cranial nerve. And that supplies the base of the brain, it also supplies your face and some of this stuff. But it's an inflammatory question of the fifth cranial nerve, and there's a certain group of people, at least 30–40%, who respond very nicely to IV Toradol. What I like to ask the serious migraine patients is, what works? And you know what? I don't care what works. But if they say, well, I've had this, that's bad, that's this or that, I think Compazine is a terrific drug. I think the combination of Compazine and Toradol in certain people works just fine. There are people who have inflammatory migraine. They get it 2 or 3 times a year. Those people respond well to bursts of steroids. But it's very individual. And just to understand, there's going to be a group of people who will not respond to anything.
Although there have been a bunch of studies that looked at Toradol in the treatment of migraine, and generally,
it's not that good.
Doesn't do crap.
Yeah. But you know what? I don't treat patients in general. I treat patients in specific. And so if that person likes it, it's okay with me.